Now, because the late 1900s is now a long time ago, it's useful to put Freud in his historical context. So this is partly history of psychology, I suppose, but it also sheds some light on how the nature of psychiatric and psychological disorders transform with time, because you tend to think of them as, especially if you're more scientifically oriented, you tend to think of a disorder or an illness as something that approximates a scientific category. But the thing about illnesses, diagnostic categories, let's say, is they're not precisely scientific categories. In fact, they might not be scientific categories at all. They're informed by science sometimes, and I would say increasingly as we develop the Diagnostics and Statistics Manual, which is the fundamental book that outlines psychiatric and psychological diagnosis, particularly in North America, but increasingly around the world. Science is being used to inform the language that sits at the bottom of the dimensions along which the pathologies are defined. So, for example, with regards to the personality disorders, there's increasing emphasis, although not enough emphasis yet, on dimensional models such as the Big Five. But you have to understand that medical diagnostic categories serve a number of purposes, and you shouldn't get cynical about this. Often people start out by thinking about diagnostic categories as scientific, and then they soon find out that the idea that they're scientific can be criticized on multiple different fronts, and quite severely. Michel Foucault, for example, has done a lot of that, and his works were regarded as revolutionary by people who didn't know anything about the history of psychiatric disorders, because most of what he outlined was already known by people who took the time to know. Partly what Foucault outlined was the fact that psychiatric diagnostic categories, like medical diagnostic categories, play a sociological and political and economic role, as well as a scientific and treatment-oriented role. And that's partly because, as I mentioned at the beginning of the lecture series, when you're attempting to move someone from abnormality, say, or ill health towards normality or health, and those aren't precisely the same, it's not precisely parallel lines there, you're doing a lot more than science. You're also involved in ethics, and you can't help it. And then, you also have to think about why it is that we have psychiatric diagnostic categories, for example. And, some of the critics of psychiatry, especially in the 1960s, regarded it as primarily an economic or political movement that was designed to categorize people who engaged in abnormal behavior and to prevent them from exercising their full rights in society, because it was thought of as a purely oppressive enterprise. Now, all you have to do is take a walk around Toronto and see all the deinstitutionalized schizophrenics wandering around, enjoying their freedom, to understand that the description of psychiatry as a purely tyrannical or oppressive sociological regime has a lot to account for. Because those people were deinstitutionalized in the late 60s and early 70s, and the institutions have never been rebuilt. And all that happened was that they were dumped on the streets, where they generally stopped taking their medication and survived very poorly. So even if psychiatry plays a sociological and political and economic role, don't be thinking that that invalidates it as an enterprise. It just means that it's a very complex enterprise that has to span multiple dimensions of... It stands on many different philosophical and scientific foundations. Now, psychiatric diagnostic categories and the symptomatology that's associated with them also transforms with time. And that's kind of a strange thing, especially if you think about psychiatric ill health as a biological phenomena. But language transforms across time too, and it's grounded in biology. And the truth of the matter is that nothing that human beings do or experience exists in a cultural vacuum. So, for example, when I was young, a common schizophrenic delusion, especially for the paranoid schizophrenics, was that the TV was talking to them. Now, obviously, they didn't have that delusion in 1920, because there weren't any televisions. So by the time it was, say, 1930, it would have been the radio. And now, the most common focus of paranoia is the internet. And there's some reason for that. I mean, because even if the TV wasn't spying on you, the internet probably is. So, that's a simple example showing how cultural transformation can change the contents and the phenomenology that's associated with a given psychiatric disorder. So you could think of them as being characterized by some combination of biology, biological pathology, historical pathology, pathology that's limited to the individual's experience, and then you can think of that all as nested inside a given cultural context, which in itself may be pathological or normative. And so, it's the interplay of all those factors that makes understanding mental illness and diagnostic categories a very challenging enterprise, especially when you also add to that the necessity for social control, which would be the political and economic dimension, and then also for intervention at the individual level. Because one of the things you want to ask yourself is, well, what serves society better? Is society served better by putting people who are completely unable of adopting normative behavior and who may be disruptive and frightening somewhere where they cannot disturb the bulk of the population? So that's question number one, and the answer to that is not obviously that's a mistake. Now it may be a mistake, and it certainly would be a mistake in some cases, but you can't just simply say that it's a mistake all the time. Because you want to be able to walk around on the streets relatively unharassed and free of fear. It's not an unreasonable desire for a civilized society. Then the next question, or maybe even the first question might be, well, do these institutions help the individuals with whom they're directly interacting? And then the right answer to that is, compared to what? Because compared to perfect, the answer is no. But compared to no help whatsoever, the answer is probably yes. And so it's also worthwhile to be useful in or to be realistic in your expectations. So for example, most people who are schizophrenic don't like to take their psychiatric medication. And the reason for that is because antipsychotic medications, which were only really popularized at the end of the 1950s, work on the biological axis, the dopaminergic system, that produces positive emotion. And so if you take an antipsychotic, it's going to flatten out your positive emotion and demotivate you and sort of take the color out of your life. And you can imagine that that's not very amusing. And then of course if you take them and you start to feel better, and maybe you're feeling better for 3 or 4 months or 6 months or a year, you're going to be thinking, well, maybe I'm better. And then you're going to stop taking them. So if you ask a schizophrenic very frequently about their medication, they'll say, well, they're not very happy to be taking it and they'd like to quit as soon as they can, but that does not necessarily mean that the medication is not doing something that's beneficial. It just means that the best they can hope for is not very good. And that doesn't point directly to a flaw in the system that's dealing with them. It just points to the terrible nature of the disease and its fundamentally intractable qualities.